And the representative of that organization said they've offered to provide funding, like municipalities have offered, foundations, charities, ethnic associations have offered to fund their trainees to come back home. Why won't faculties of medicine accept that funding, but they do accept funding from Saudi Arabia?
An increase of more than 400% in less than 10 years.
Is it possible that you're not aware that the Saudi government makes donations to the University of Manitoba for taking on these Saudi students?
So this guy's garage. Like and subscribe.
With us here, 3 witnesses for the second hour, and it's Dr. Aaron Bury, Chief Executive Officer of the Canadian Dental Association, Dr. Kerry McAdoo, Physician Assessment Centre of Excellence, Chief Executive Officer, and on virtually we have Dr. Peter Nickerson, Association of Faculties of Medicine of Canada.
Dr. Nickerson, thank you so much for your remarks, and I just want to quote from the briefing materials you sent us, because I think it's so important, and I feel like the committee has missed this point several times. You say that the fact that we are able to accommodate externally funded visa trainees tells us that there's further training capacity in the health system. Do you have reflections on that point? Like, it seems to me that every spot that goes to a visa trainee could be going to a Canadian if they were properly funded. Is that a good paraphrase of what you said there?
Right. So I think the answer is the health system pays for residency positions. They pay the salary of these individuals, and they pay the associated training costs to the universities to oversee them in their programs. It's really up to the provinces to decide how much they're going to fund, how many residency positions they're going to create.
Thanks. And then, so I have a follow-up question about Saudi trainees in particular. Could you give us an idea of how much funding medical schools get per Saudi visa trainee and how that compares to comparable provincial funding across Canada?
Right. So the cost that is per trainee, I believe, and I'd have to get back to you with the exact number, but I believe it's around $70,000 a year. The cost for training a Canadian individual is at the same level. So we basically are charging what it would cost us to train an individual, Canadian individual.
So I just want to make sure that that's on the record then, because there have been different things have been said. So your understanding is the Kingdom of Saudi Arabia gives the same amount of money per visa trainee that a province would give to a Canadian trainee?
Would give to in terms of, I'm talking now about what funding comes to the medical schools to support the training program, correct?
Okay. Could you table data to that? I would love to see it in black and white.
We can get that.
Okay,
get that information for you.
So my understanding is there's 1,000 Saudi visa trainees in Canada. So 70,000 times 1,000 is, I believe, 70 million, which on the scale of the federal government of Canada is not very much money. And so I want to tell you a story about why I feel personally scandalized about this. So in August of 2018, I'm critical of Chrystia Freeland for many things, but in 2018, she called for the release of human rights activists in Saudi Arabia who'd been imprisoned for like 5 years because they wanted women to have the right to drive. And then Saudi Arabia pulled funding for these visa trainees, said they were going to take their trainees back. And I was teaching at Queen's University Faculty of Medicine at that time, and the administration lost their mind because of the dearth of funding that this would cause. A few months after that, Jamal Khashoggi was brutally murdered and dismembered. He was a Washington Post journalist who was murdered with a bone saw. And that sort of repression continues in Saudi Arabia to this day. So they just executed this summer a journalist for criticizing the government in tweets. So I felt like personally morally scandalized that the faculty of medicine that I was at was lobbying the government to get this money back from a brutally repressive dictatorship. And I wondered if you had reflections on that. Like, do you think that receiving this amount of money from a brutal, repressive dictatorship morally compromises faculties of medicine in Canada?
So I don't know that I'm necessarily qualified to answer that question. What I can tell you is we provide the same level of training to these individuals from who are visa trainees in general. I think the ideal would be that we actually fund more of our own capacity for training residents that we are going to stay here in Canada. Overall, I think that's the biggest gap that we have across the country is a number of residency positions where we have the opportunity to maintain those individuals working in Canada to meet the needs of Canadians.
Okay, I'm going to push you a bit on that because I think we all have to be kind of qualified to make our own moral decisions in life. So the faculty of medicine that I was at was lobbying the government and basically criticizing Chrystia Freeland's criticism of Saudi Arabia's human rights record in order to get that money flowing back into their medical school. So do you recall that episode? Like what thoughts did you have about that episode? Which faculty of medicine were you associated with at that time? Was that faculty of medicine also criticizing Chrystia Freeland for criticizing the brutally repressive regime in Saudi Arabia?
So I would have been at the University of Manitoba. I would not have been in my role at the time as dean. University of Manitoba does not look at visa trainees as a mechanism of funding that we're dependent upon. We look at the provincial funding that we get to the medical school as being our core funding. If we're funding for visa trainees, that's the capacity that we've allowed within the system, but it's not something that we're lobbying anybody for.
Thank you. So we have heard testimony from a group that represents
44 seconds.
Canadians who graduated from medical school abroad, want to come back. There's about 800 a year that can't find a spot through CARMS. And the representative of that organization said they've offered to provide funding, like municipalities have offered, foundations, charities, ethnic associations have offered to fund their trainees to come back home. Why won't faculties of medicine accept that funding, but they do accept funding from Saudi Arabia?
So again, I can't comment on individual
12
offers from
seconds.
Municipalities because we haven't received that. What our government has done in Manitoba is given us sufficient funding to have a ratio of 1.72 currently, so we can actually repatriate Canadians back into Manitoba along with other IMGs.
Thank you. That's the end of that session, Mr. Strauss. I go to Mr. Pulowski for the Liberals for 6 minutes.
Dr. McAdoo, do you get federal funding from the province?
Correct.
And so the money comes in because, like a dog, I still practice a bit of medicine. I get fee for service. We bill to the provincial healthcare system. I get paid. Does that 100% fund your PACE center?
The provincial government funds it.
Does it does it directly rather than, so you get an annual amount rather than getting paid per patient seen, per services provided?
That's correct. It's an annual amount because it is both providing healthcare as well as providing assessment. So it's not a typical clinic in that regard.
Okay, so the amount of money, like this is, I would think then this is not, you don't do a high volume of patients. So if you were a doctor practicing in Nova Scotia and you're trying to make a decent salary, you'd see lots of people. And as a result of seeing lots of people, you'd make lots of money. But with this PACE center, they're paying more, I would think, because you're teaching people, and so you don't have to see nearly as many. So I'm just wondering about the efficiency in addressing the healthcare shortage. The efficiency and the point is to train people, not to see a lot of people.
It is a different model than a typical clinic, for sure. The funding model is based on the number of assessors in the clinic. And the assessors oversee the work of the internationally trained physicians. And so we expect that the team would see as many as a full-time family physician would for the funding model. So it's not the volume that you would expect in a typical clinic because there's time built in for the assessment work, both for the assessor and for the international trainee.
Now, why, and maybe Dr. Nickerson can chime in here, why do you need PACE? Why couldn't you just have doctors in the community playing the same role with supervising somebody doing a practice-ready assessment? I think the answer is, and maybe Dr. Nickerson can address it, it's hard to find a number of people who are willing to do the assessment for PRAs. Is that part of why you exist, because of the difficulty in getting people doing PRAs in community?
Yes, there are definitely challenges in recruiting and retaining assessors in the traditional practice-ready assessment model. The challenge in the previous model that other PRAs operate with, physicians are asked to provide assessment every year or two and may not be doing it regularly, and so they may not maintain their confidence to provide that assessment work. With PACE, the assessors are providing assessment work on a regular basis and feeling confident with that work. They also have extensive training with the Medical Council of Canada, and so they're feeling confident that they have the skills they need to do that work. With this centralized model of PACE, they have developed a community of practice, so they provide support to each other and are able to work together to build their skills, and they're compensated as well.
In your program in PACE, is it open to physicians from any country, or is there some sort of like decision that certain countries are going to produce higher level graduates, or is it kind of all comers?
It really is based on the competency that we expect to see in the clinic. So we have eligibility criteria that are set by the College of Physicians and Surgeons of Nova Scotia, and then selection criteria on top of that. So we don't identify specific countries. It really is looking at who would be most successful.
And Dr. Nickerson, I know in Manitoba they've been doing PRAs for a while. My understanding is isn't it fairly limited numbers? My guess was something like 30-something per year in Manitoba. And why don't they do more? And is PACE perhaps the answer in terms of perhaps Manitoba ought to do something similar so that they could get a lot more people out through that kind of approach?
So I think it's a great question. We actually launched back in around 2000 doing PRAs initially without quite the standardization as you've heard from Dr. McAdoo. We found that didn't necessarily meet the needs of the international trained physicians. So we moved to a one-year program where we essentially give them rotations through various areas, emergency medicine, family medicine, pediatrics, to give them a broader orientation to the Canadian healthcare system. And we found that one-year program to be highly successful. Over the years, we've had 20 per year go through that program. We've ramped it up now to 30. We are ramping up a PRA program, very similar to where Dr. McAdoo is doing. In Manitoba, we are spending time, though, getting the assessors well-trained through MCC and developing the same kind of community of practice in Manitoba. I do think, like Dr. McAdoo, it requires some screening for who's eligible for the PRA, because you only have 3 months generally to do the PRA, and that really requires that you have a wholesome assessment so that you can really sign off that they're ready to practice.
Okay, thanks. And I want to get in, and I think this is a really important question. My understanding...
I'm sorry. I've been so interested in this question, Marcus, that I have let you go. You've got 9 seconds left.
I understand there's a group of facilities that offer PRAs that meet and try to set national standards, and you're interested in a CARMS kind of program for PRAs nationally. Is this something that perhaps the federal government should look to fund?
I think you're referring to the Medical Council of Canada. I'm not sure if that's what you're describing, but they do have a national assessment collaborative through the MCC that brings various PRAs together. I think that's what you're describing.
When it comes to dental care being administered through the Interim Federal Health Program, has the number of dental users increased over the past 10 years?
I wouldn't have that information. I have to get back to you in terms of that particular program. It's a federal
The numbers that the government is giving are that show that there is a 464% increase since 2016 and more than 110,000 more users. So with that many more users to this health program, what kind of bureaucratic hurdles or delays does that place on dental offices?
So in terms of that program, it's a very limited program, primarily focused on very urgent and emergent care. So I think the biggest issue with the program is exactly that. People are arriving with needs that are far greater than that program is designed to actually deliver.
I was wondering about that because actually, hats off to my local Rotary Club that I belong to. We've been fundraising for local Ukrainian children for their dental service, and I was wondering why they weren't being serviced, and yet so the cost has gone up to 256 million. And a decade ago it was only 13 million. So my question is there a different process that dentist's office must take with the Interim Federal Health Program dental coverage if services are rendered to a refugee applicant whose application has been rejected by the Immigration and Refugee Board as compared to if it's an approved refugee?
So I would have to get back to you on the details of that. It's been a while since I've actually treated refugees myself under that various program, as well as both publicly. There are many different classifications of individuals coming in, and each one of those may have a different approach.
You could table that for me, that information when you
Certainly.
receive it? Okay, that'd be great. And one more question actually, I think I'm going to turn my questions over to Mr. Mazur at this point.
Thank you. Madam Chair, I have the floor. I would like to move the following motion, since we're getting close to 1 o'clock. That given that the cost of the...
Excuse me, are you taking some of Ms. Conan's this time?
I'm moving the
All right,
I did say
good.
that, yes.
Okay,
Yep.
thank you.
So I'm moving that since the cost of the interim federal health program has increased from 66.3 million in 2016-17 to 797.2 million in 24-25, an increase of more than 1,100% in less than 10 years. And given that the total number of users that incurred interim federal health program claims have risen from 84,967 users in 2016-17 to 426,750 in 2024-25, an increase of more than 400% in less than 10 years. In Quebec alone, the number of users that incurred interim federal health program claims have risen from 11,900 users in 2016-17 to 108,440 in 2024-25, an increase of over 810% in less than 10 years. During the Health Committee study on the impacts of immigration policy on health care in Canada, the committee heard testimony regarding a lack of program insight, questionable billing practices, and a sharp rise in program usage and costs for the interim federal health program. So I move that the committee instruct the chair to write to the Auditor General of Canada suggesting she conduct a comprehensive audit on the federal government's interim federal health program to examine the significant increase in cost, usage, and impacts on provincial healthcare systems by February 7th, 2026. B, instruct the chair to write to the parliamentary budget officer requesting that he conducts a fiscal analysis of the interim federal health program to protect future expenses and assesses the drivers behind recent significant costs and usages increased by January 30th, 2026, and C, invite the Auditor General of Canada and the Parliamentary Budget Officer to appear before the committee separately to present and discuss the respective findings if they publish a report. So I so move that, and I just saying from what we've heard here in over the last committees, I think this is a very important subject, and we really do have to get a handle on this, especially on this important subject.
Yeah, I hope everyone has the motion. Madame LaRoche, did you get the motion in front of you? Thank you very much. So now I'll call the vote on the motion. Would you like a recorded okay?
vote.
Recorded? So, clerk, sorry.
Ms. Chi.
No.
Mr. Elson.
No.
Mr. Polanski.
No.
Mr. Garrier.
No.
Mr. Mary,
Yes.
Ms. Gonans,
Yes. Yes.
Mr. Mazier,
Yes.
Mr. Strauss,
Yes.
Madame Larouche. Yes, 5, nays 4.
The motion is defeated. Oh, sorry, passes. And I don't know, we have 4 minutes if I'm sorry, I see someone here left on virtual. Yes, and then we have the two. Would you want to take another 4 minutes?
All right, thank you, Chair. Sorry about the interruption, folks. Part of how committees work, these things happen. So, Dr. Nickerson, Doug Elfson, good to see you again. It's been quite some time. You talked about the cuts in medical school and residency positions since the 1980s and how it has been improved. And you had said that this was the provincial governments that were cutting those. Is that right?
Yes. So the provincial government set the seat numbers that the universities can have, and they were all decreasing through the 80s into the late 90s, and then they were ramped back up again to the level that they are today.
Mm-hmm. All right, thank you. Now I know having served in the federal government before and being back now, I know that there is difficulty in trying to sometimes coordinate with provinces. We want to encourage provinces, to do certain things like funding spaces. We tend to get pushback if we designate any funding toward any particular initiative. Would you encourage the provinces, the provincial governments, to work, with the federal government to increase the number of medical school and residency spots?
Yeah, I think that's what we really need is federal-provincial cooperation to further increase the current capacity. If we compare ourselves to other OECD countries at the current level of 93 per million, we're certainly, on average, we're well below what is occurring in Australia or UK, which is up in 120 to 130 per million. So I think there's clearly other countries that are outpacing where we're at today.
Mm-hmm. All right, thank you so much.
Thank you, Madam Chair. Through the chair, I'd like to speak with Dr. Nickerson from Alberta, or from Manitoba, please. Through the chair, could you clarify? You said $430,000 to train a medical student. In Alberta, they're claiming it's over $1 million. I'm wondering, are you including the stipends that they would receive?
No, I was quoting based on a Senate document from 2002 and adjusted for inflation as a Canadian average.
Thank you. Could you tell me how many CARMS matches are there in Winnipeg? And just give me a general breakdown, being family medicine and then, of course, the rest being specialist. Would you have 90 spots?
No, we have 190 spots that we offer. And in terms of family medicine, we have 82 family medicine spots.
82. Is it possible that you're not aware that the Saudi government makes donations to the University of Manitoba for taking on these Saudi students?
So we don't have donations as far as I'm aware. What we have for visa trainees is a set amount that they pay the institution for training those individuals.
Would you be aware if the Saudi government is giving donations to the university, or would that be something that you would not be aware of?
I would not be aware of that.
Okay. I appreciate that. Is there anything that requires your graduates from your CARMS match to stay in the province?
For the Canadian medical graduates, no. We have a return of service for international medical grads to stay in Manitoba for a period of time.
Thank you. Through the chair, Mrs. McDough, thank you for the work that you're doing. I have not been to your center yet, but I have spoken to many people that have. And I would like to ask you, what sort of challenges did you face when you were starting up your program? And what kind of challenges, I guess, what kind of challenges have you faced? And do you think this is something that could be incorporated into other provinces?
Thank you for that. There were a lot of time pressures, for sure. It was announced in October, and we were operating in January, started our first assessments in February, so time was definitely a pressure. Finding enough clinic space in that short period of time was a challenge as well. So we were constrained by the number of assessments we could do based on the number of clinical exam rooms we had available to us. And that's why we're opening another space in December. And we had to obviously recruit all of our team and our candidates and our assessors, and so that was part of it. We were building the program in a very quick period of time. We now have a very strong foundation and have proven that it is scalable. We've scaled already and are still in our rapid growth phase. So we started at a very small number of candidates and are increasing them on a regular basis, and we'll double our capacity in December for the office-based primary care program. The challenges ahead, we are going to be looking at expanding the orientation program, potentially that's run through the College of Physicians and Surgeons, to expand its scope and hopefully breadth. We will also be looking at building purpose-built space so that we have more space to do these assessments and continue to develop the program. Of course, we're going to get into program evaluation as well. We'll be collecting a great deal of data, which will help with informing how these types of programs move forward. And so to answer the final question, which I believe is, could it be done in other areas? It is certainly scalable locally. It could be done on a regional basis. As we scale up, we will have capacity to do that type of work, and it could be done in other provinces as well if there was a will to do so.
Thank you so much.